Hi, I'm Sarah Arkle and welcome to today's session. Today's session is all about understanding your baby's journey from conception to birth. Today we'll cover lots of different topics, but some of them might be sensitive. Please do speak up or indicate if you're finding it difficult or have any questions. Ask away, and no question is silly or stupid, and I'm sure other people will be grateful that you've asked the question for them. So here's what we'll be looking at during this session. We are going to cover how your baby grows and develops during pregnancy, ways that we check your baby and your health during pregnancy and labour, the available tests to screen for genetics and health conditions, risks of miscarriage and what support and treatments are available, and also when and how pregnancy may need to be ended for medical reasons. So first, let's take a look at how your baby grows. So in the first few weeks of pregnancy, they're known as the first trimester. So you have 3 trimesters. So week 1 to 12 is the first trimester. In weeks 1 to 4, after fertilisation, the tiny balls of cell, known as the blastocyst, which you can see just here, implants in the womb and starts forming essential structures like the brain, spine and heart. During weeks 5 to 8, the heart begins to beat, arms and legs form and facial features start appearing. By week 8, your baby is called a fetus. So as the pregnancy progresses into week 9, organs like the brain, the heart and the kidneys start to develop, and your baby will be about 5 centimetres long at this point, and they'll start to look a little bit more human, or what we see as human. Even in this early stage, your baby will be developing early reflexes like sucking. So in the second trimester, which are weeks 13 to 26, we see rapid growth and development of muscles and bones. And at this stage, the baby's skin is covered in fine hair, or what's known as lanugo, and a protective coating called a vernix. By week 20, your baby is about the size of a banana, and it can hear sounds and respond to touch. Let's move on to the third trimester. The third trimester, the lungs and the brain mature and fat stores build up, and your baby prepares for life outside the womb. By week 40, your baby is fully grown and weighs an average of 6 to 9 pounds. It can respond to voices and light and practice movements like kicking, so you might be able to feel it by then. Now we'll take a look at how we monitor your baby's health during pregnancy. You may have heard of this way of monitoring your baby during pregnancy. Ultrasound imaging is one of the safest and most common ways that we check your baby during pregnancy. It uses sound waves to create pictures of your baby and monitor their growth and health. So you usually have 2 scans during your pregnancy. The first one is in weeks 11 to 14, and that's a dating scan. So this scan confirms how far along you are and checks your baby's development. And then you'll have a second scan at around 20 weeks, which is called an anomaly scan. And this is a more detailed look at your baby's organs and growth rate. There are 2 main types of ultrasound scans, external and internal. An external ultrasound, called the transabdominal ultrasound, is the ultrasound most people are familiar with. It uses a small device called a transducer, and it's moved over your belly after we apply a little bit of gel. The gel helps the sound waves pass through to get a clearer picture. And then this is used in early pregnancy dating scans and later pregnancy at the anomaly scan. It's completely non-invasive and painless and quick. You can see your babies on the screen during the scan, so it's a special moment for lots of parents. And then there's the internal ultrascan, or the transvaginal ultrasound. This type of ultrasound uses a smaller device that's gently inserted into the vagina. It gives us a closer and more precise view of your uterus, cervix and the baby, especially in early pregnancy when everything's very small. This type of scan is used in early pregnancy, so if you're less than 12 weeks pregnant, it's often the best way to see the baby. This type of scan can help us to confirm a healthy pregnancy and detect issues like ectopic pregnancies. It's also used in later pregnancy to check the length of your cervix if there's concern about preterm labour, and get clearer images of the placenta or the baby if needed. So it's slightly more invasive than an external ultrasound, but it's not painful. It's just a little bit uncomfortable, and the procedure is done in privacy, and we ensure you're comfortable as possible. We'll usually use an external ultrasound as your pregnancy progresses, and we might recommend an internal ultrasound if we need more detailed information, particularly in early pregnancy, or to investigate specific concerns. Both types of ultrasound are entirely safe for you and your baby, and they don't use radiation, just sound waves, which we've been using in pregnancy care for decades, so they're totally safe. So the next type of scan we use is the Doppler ultrasound. Doppler ultrasound is a helpful way to check your baby's health. It's safe and painless and gives us valuable information to ensure your baby is getting everything it needs to thrive. It's slightly different to an ultrasound because it focuses on blood flow rather than just creating images. Doppler ultrasound uses sound waves to measure how blood moves through vessels, like ones in your baby's umbilical cord, brain or heart. It helps us ensure that your baby gets enough oxygen and nutrients from the placenta to grow and develop. The scan is very similar to a regular external ultrasound. We apply gel on your belly and use a handheld device like this one. It's called a transducer to send sound waves into your body. You might hear a whooshing sound during the scan. This is the sound of your baby's blood flow, so there's nothing to worry about. It's totally normal. Doppler ultrasound is entirely safe, again, for both you and your baby. It's non-invasive and it doesn't use any radiation. Again, it's just sound waves. If everything looks normal, that's excellent news, and then no further action is needed. But if we do notice something unusual in any of these scans, we'll discuss it with you and decide the best next steps, which might include more scans or closer monitoring. And the last measurement we use to monitor the baby and its growth is a simple measurement from your pubic bone to the top of your womb to check how your baby is growing. Measuring fundal height is a simple and non-invasive way for us to keep an eye on your baby's growth during pregnancy. It gives us a general idea of how things are progressing and can help us spot potential concerns. However, it's not always an exact measurement, and sometimes the measurement can vary depending on things like your body shape or how the baby is positioned. However, that's why we use it alongside other tools like the ultrasound scans to get a clearer and more detailed picture of your baby's development. By combining all of these methods, we can ensure that your baby is growing as expected and address any concerns early if we need to. Okay, so let's take a look now at how we monitor you and your baby to keep you both safe during labour. So monitoring your baby during labour ensures your baby is coping with the stresses of labour, and we can monitor the baby in two different ways. Let's have a look. So the first one is using intermittent checks and listening to your baby's heartbeat with a Doppler at regular intervals. And the second one is with continuous monitoring, so the CTG, where we use a belt to track your baby's heart rate and your contractions, so it goes around your stomach. It's common for high-risk pregnancies to have this, or if you're having twins or you've got high blood pressure. Changes in your baby's heart rate might mean we need to adjust your birthing plan, such as using forceps or vacuum delivery or a cesarean. But again, you'll always be included in any of these decisions if we need to go down that route. So we'll also monitor you during labour, and here are the ways we will do that. We monitor you during labour in 2 ways to ensure your health and safety during delivery of your baby. The first way is your contractions. So the strength, frequency and timing of your contractions are measured to ensure that labour is progressing as expected. We assess how your cervix is dilating and how your baby is moving through the birth canal. Sometimes the information we gather suggests that labour isn't progressing as we'd like it to or as expected. For example, if there's slow progress in labour, the cervix isn't dilating or your baby isn't moving down the birth canal, we might recommend interventions like using medication such as oxytocin to strengthen your contractions, or we might help your baby out with forceps or vacuum device if they're close to being born, or moving on to cesarean, but only if necessary. So with this in mind, it is important to keep an open mind regarding your birthing plan, as things can change. We'll always explain what is happening and why we're recommending changes, and we'll make sure that you're involved and that you're part of the decision-making process as much as possible. Our priority is to keep you and your baby safe during labour, and any changes are made with that in mind. We also may recommend additional monitoring to make sure that you and your baby are doing well. So this might be suggested if you are high risk pregnancy, or if your labour doesn't go as planned. Like I said, if it slows down, or if we notice that the baby's past meconium, so they've had their first poo, but they've done it in the amniotic fluid, or if you're induced as well, we may require some extra monitoring then during labour. We'll also use it if there's any concerns about the baby, like I said, if you've had reduced movements, or if the heart rate reduces or changes. Also, if your baby's breech, we may require some extra monitoring. If you've had a previous pregnancy, or you've had labour complications, or if you're planning a vaginal birth after a previous C-section, then we might use monitoring then as well, or if you're using certain pain relief. And if your labour is before 37 weeks, or if you're overdue, then we will then also monitor you just to make sure everything's okay. The goal of extra monitoring is to keep you and your baby safe. Again, if we recommend it, it's because we want to catch any potential issues early and respond quickly if needed. We'll always explain what's happening and why, so you never feel left out of the process. Okay, so we're going to move on to discuss screening during pregnancy, why and how we do it. So screening in pregnancy is an important part of making sure your baby is growing and developing as expected. Screening helps identify conditions that might affect your baby's health, giving you and your healthcare team time to plan for the best care possible. Screening tests don't diagnose problems, but they indicate whether further tests might be needed. One screening that is offered during pregnancy as routine care in the UK is screening for Patau's, Edwards and Down syndrome. Here's a quick breakdown of those syndromes in case you're not familiar with them. Down syndrome is a genetic condition where you're born with an extra chromosome. It can affect learning ability and physical development. It may include some medical challenges. Edwards syndrome and Patau's syndrome are rare genetic conditions that cause severe developmental issues. Babies with these conditions may not survive long after birth. So we use 2 types of screening to assess if your baby has a higher chance of being born with these conditions. The first is a combined test, usually taken between 11 and 14 weeks. This includes a nuchal translucency scan that measures the fluid at the back of the baby's neck during an ultrasound. And then there's also a blood test which measures hormone levels in your blood that can indicate a higher chance of these conditions being present. Results are combined with your age to assess the likelihood of those conditions being there. The second type of screening is a non-invasive prenatal testing, which is NIPT, a blood test that examines tiny fragments of your baby's DNA in your blood. It's highly accurate for detecting Downs, Edwards and Patau syndrome. If the screening suggests that you've got a higher chance of these conditions, diagnostic tests like amniocentesis or chronic villus sampling may be offered to confirm that your baby does have these syndromes. Another screening test we offer during pregnancy is for sickle cell disease. This is a genetic condition that affects red blood cells, causing them to become misshapen and affecting the transportation of oxygen around the body. It can lead to pain, infections and other complications. In the UK, sickle cell disease is one of the most common genetic conditions. So though SCD, as it's also known, is more common in individuals of African, Caribbean, Mediterranean, Middle Eastern and South Asian descent, screening is offered to all pregnant people in the UK as part of antenatal care. Fathers are also tested if the mother is found to be a carrier, as the baby is only at risk if both parents carry the gene. A simple blood test is used to detect sickle cell disease, and it's done in early pregnancy. If both parents are carriers, you may be offered further testing to check if the baby has inherited the condition. So we can also screen for fetal anemia, which occurs when your baby doesn't have enough red blood cells to carry oxygen around the body. It can be caused by conditions like rhesus disease or certain infections, for example, herpes or toxoplasmosis. It can be detected using Doppler ultrasound, which we saw earlier. In this instance, we measure blood flow in your baby's brain, which can indicate anemia. In mild cases, regular monitoring and possibly early delivery are used to treat this. In more severe cases, it can be treated with intrauterine blood transfusion, which may be given to the baby while still in the womb. So armed with all the information provided to you, you may need to make the difficult decision to terminate your pregnancy. So let's take a look at some of the options available to you. Termination of pregnancy can be a very personal and sometimes necessary decision. It can be carried out for various reasons, such as concerns about the baby's health, risks to the mother's health, or other personal circumstances. In the UK, two main methods are used. That's a medical termination and a surgical termination. Both options are safe and effective, so let's take a look at them in a little bit more detail. First, let's look at medical termination. Medical termination uses medication to end the pregnancy. It's usually offered if you are less than 10 weeks pregnant, although it can also be used later in pregnancy if necessary. It works by taking a tablet called mifepristone, and this blocks the hormone progesterone, which is needed to maintain the pregnancy. Then a second tablet, misoprostol, is taken 24 to 48 hours after the first tablet. Misoprostol causes the womb to contract and expel the pregnancy. You can experience cramping and bleeding similar to a heavy period, and this is the sign that the process is working. You may have a follow-up appointment to ensure the pregnancy has fully passed and to discuss any concerns or if you need any support. The second option for termination in the UK is surgical termination. This involves a procedure to remove the pregnancy from the womb, and there are two ways of doing this. They are usually recommended after 10 weeks of pregnancy or if medical termination isn't suitable. The first surgical method is vacuum aspiration, which can be performed up to 14 weeks of pregnancy. It's a gentle suction device that removes the pregnancy from the womb, and it can be done with local or general anaesthetic. The second method is dilation and evacuation. This method is recommended after 14 weeks of pregnancy and involves gently widening the cervix and using instruments to remove the pregnancy. General anaesthetic is usually used for this procedure. The procedure itself is quick and often lasts 5 to 10 minutes. It's important to remember that having a termination will not affect your ability to have children in the future. After either type of termination, your healthcare team is here to support you emotionally and physically, and counselling services are available if you need to talk about your experience. So next we're going to talk about risk factors for miscarriage and possible treatments. While it can be difficult to experience miscarriage, understanding the risk factors and available treatments surrounding miscarriage can help you feel informed and supported. So it's important to talk about it. Again, if you feel uneasy about this, please do indicate to me, or I'm happy for you to leave the room. Miscarriage is the loss of pregnancy before 24 weeks, and it's more common than many people realise, with around 1 in 4 pregnancies ending this way. There are some risk factors associated with miscarriage. They can be maternal age. So for example, the risks increase as you get older. Under 25s face a risk of about 10 to 15%, but over 40s face a risk of over about 50%. Health conditions can also be a risk factor. For example, if you had diabetes and it was not well controlled, or you have a thyroid disorder, they can increase your risk. Infections can increase your risk, like rubella, listeria, or toxoplasmosis. They may lead to miscarriage. Also, lifestyle factors come with some risk. So smoking, heavy alcohol use, recreational drugs, they all can increase the likelihood of miscarriage. Being underweight or suffering from obesity may also contribute to risk too. Being underweight or suffering from obesity may also contribute to the risk. The most common case of miscarriage, around 50% of cases, is chromosomal abnormalities, chromosomal issues in the baby that prevent proper development. Previous miscarriages may also increase the risk of future pregnancy loss. But most miscarriages occur as a result of chromosomal abnormalities and not external factors like stress, physical activity, and sexual intercourse. It's important to remember that miscarriage is common and often beyond your control. Treatments are available to safely manage the miscarriage, whether you choose expectant medical or surgical methods. The method will differ on how far along the pregnancy was and your personal preferences. Expectant management is letting the miscarriage progress naturally without medical intervention. It's suitable for early miscarriages, which are under 10 weeks with minimal symptoms. You may experience cramping and bleeding, which will occur as the pregnancy tissue is passed. Medical management is where medication is used to help the womb expel pregnancy tissue. Tablets such as misoprostol are given either orally or vaginally to induce the contractions. This can be done at home or in a clinical setting. And then surgical management is a procedure to remove pregnancy tissue from the womb. Again, a manual vacuum aspiration is a minor procedure that is performed under local anaesthetic. It's often used for early miscarriages, and it's where a small tube is used to gently remove the pregnancy tissue. There's also dilation and curettage. It's a more common procedure for later miscarriages or if there are complications. It's performed under general or local anaesthetic, and it's where the cervix is dilated and tissue is removed using a suction device or surgical instruments. D&C, as it is known, is typically done in a hospital setting. Miscarriage is a deeply emotional experience for many, and it's important to seek support. Many hospitals and organisations like Tommy's and Sands offer counselling and emotional support. Your GP or midwife will ensure you receive appropriate aftercare, including discussions about future pregnancies and planning. Thank you for coming along today. I know that this is a lot of information to take in, and we've covered a few sensitive topics like the tests that are available to screen for genetic and health conditions, risk of miscarriages and what support and treatments are available, and when and how a pregnancy may need to be ended for medical reasons. We also looked at how your baby grows and develops during pregnancy and how we monitor you and your baby's health during labour. Please do come and speak to me at the end if you find it difficult to speak up, or if you have any questions at all, or you need any advice, or you're worried about something, then we're always here to support you. That's been great. So thank you very much for listening. And I look forward to your feedback.